Arthritis is one of the most common diseases in the world. It affects around 500 million people worldwide. Most of the people associate the disease with an old age, but also young people can suffer from arthritis. But why do we even develop the disease? What are the risk factors? And what new hopes can bring us the regenerative orthopedics? We will now answer these and other questions for you together with our expert. He's not just only our ETH professor, no, but also the former head of orthopedics at SportClinic in Zurich and also the medical director of the SportClinic, also in Zurich. Mr. Steinwachs, welcome and thank you for taking your time.
Thank you for the invitation.
So, Mr. Steinwachs, how did your academic career started?
I start after finishing my normal student work with academic work in a laboratory. So my first contact to regenerative medicine was based on cell cultures. So my PhD work was based on chemotherapeutics with tumor cells. Under this condition, I learned to work with cells and biological molecules. And for that reason, I decided afterwards to go in a field of musculoskeletal disease. And I look for assistant work in a university hospital in Freiburg. And there I start and I see that mostly the people treat the osteoarthritic knees with artificial joints. And for that reason, I remember what I have learned before, and I say, oh, could be there is a chance for regenerative medicine. At that time, there was nothing, only artificial joints. And so I start with pick up the surface from joints, the deteriorated cartilage pieces, go in a laboratory, release the cells, and cultivated the cells. This was my first work in this field.
Mm-hmm. So, is this also your specialty is it the specialty in your field?
Yeah.
Okay.
It's definitely the special part, but I have to go through the standard education, what I have learned to implant an artificial joint, to do surgeries on lumbar spine, on pelvic, on knees, whatever.
Mm-hmm.
So but it was the initial motivation to see a musculoskeletal system has definitely a limit in regenerative medicine, and so I start with that work. This based for everything. Afterwards, I go 15 years on a university hospital. I built up special departments for regenerative medicine in orthopedics. And then I go to Zurich. I was the head of SportClinic. And so it goes further.
Yeah. So now, Mr. Steinwachs, what is the cause of arthritis?
This is not really answered yet, but for sure we know many different factors which play an important role for this disease. One is the genetic ones, so we call that primary osteoarthritis. And we have also secondaries which are related to any musculoskeletal injuries like ligament ruptures, cartilage deficits, we have axis deviation, we have meniscus loosening, so many things which related or go in a field of osteoarthritic joint.
Okay, and
so it's a mechanical factor.
Definitely.
Mm-hmm. What are the typical starting signs of arthritis?
We have an early osteoarthritic, we have a mid-size and a final. And if we look here on the pictures, for example, I opened that, we see the normal curve. So initially, the patient have 100% function at their birth. And afterward, they lose the function in a called pre-osteoarthritic. And if they come up with an injury, so any damage was directed in the joint, then start the course. And starting the course means initially you have an early osteoarthritic knee. This is mostly not symptomatic. So the patient don't realize that mostly. And in the mid-size osteoarthritis, they come up with symptomatic in higher activity like sport. And the final one, if the joint is completely deteriorated, then they have pain. You see the yellow curve, this was a picture what I create for publication. The pain increase with the course of OA. So initially in this stadium, the pain is quite low. For that reason, mostly you see people with osteoarthritic in a late final stadium of the OA, not in an early one.
And I mean, this is for the patient, right?
Yeah.
I mean, they don't feel the symptoms
Yeah.
like at the beginning. So at what point should you seek help if pain in the joints and ligaments? I mean, for me, I play volleyball, for example, and yeah, I have some knee pain here and there, but it's never enough to really consider getting help. So
it's difficult, indeed. Mostly, for me, the most relevant point is sign of inflammation. If you get after activity a sign of inflammation, means a swelling, warming up, some more fluid. These are more related to the mechanical surfaces in the joint. And the reaction is based on synovial reaction, like an inflammation. And if anything is worse on the mechanical surfaces of the joint, it reacts mostly with an inflammation. So inflammation is a good sign. The rest, like pain on the ligaments, pain on the muscles, this is normal that everyone has, with or without osteoarthritic knee. So the sensitive factor is the inflammation in the joint. This is the sensitive one.
Okay. And what are the risk factors for getting then arthritis?
There is one of the big risk factors related to sport, and we are in a sport clinic, are overuse in sport. That's for true. And there are more risky sport parts like football, like all the pivot shift sports means where you have a lot of turns and twists and jumps. This is high energy which will be applicated on the surface of the cartilage. And the cartilage has a low capacity for regeneration, means these overloads, impulse, create more and more damage in the joint over the time.
And what would you say, how big is the role of the genetics in the risk factors?
Mostly 50% plus, that's for sure. We see in the history of our patient mainly that they documented that the parents or grandfathers has also been problems with the knee. In some cases, it is like they have a genetic fixation on a deviation of the joint, means the patella is not running exactly, or mostly they have varus or valgus knee genetically fixed, and these create osteoarthritic knee. Okay, so it's difficult. Sometimes it is a musculoskeletal limit. Sometimes it's a genetic metabolic limit that the joint cannot help itself by a genetic deviation. This is a more rare. The other one is more common.
You said that the cartilage isn't really regenerative. So why is that? That's actually like not really good for our body in hindsight, yeah.
And you have to know that the joint itself is mostly covered by a joint capsule, and the internal environment is separately from the whole other system. There's only a fluid which will synthesize by the synovial tissue, which gives some nutrition, but the metabolic activity is very rare. So the joint has a low metabolic activity and a low nutrition, and for that reason a low regeneration. So the mitotic activity of the cells, which are mostly the main issue for regeneration of tissue, it's very rare. 5% of the whole tissue quality is cells. The rest is extracellular matrix, which will be deteriorated under sport overuse or whatever.
Do you think, will there ever be a cure to arthritis?
There are many information academically on the background. So there are some genetic deviation that the fluid which will be synthesized on the surface of the cartilage is the first degradation what we see, for example. And the idea is to give a genetic stimulation to produce this factor again. So it's like a molecular level to restore some deficits in the joint. And we have in the future perhaps the chance to pick up some genes which are damaged and related to osteoarthritis and restore that again. But this is the future vision.
I remember a conversation that we had in the ETH together with David, where we talked about the regenerative orthopedics.
Yeah.
What kind of role will play that for the patients that have arthritis?
In general, it is a way to conserve the own joint by stimulating regenerative processes for healing. So we ignore that many years, and the answer for from the orthopedic surgeon was you have to put in a new joint, and then they come up to learn under new techniques that there is a chance to stimulate the body to regenerative for itself, but it is complicated. So for 15-20 years we don't suture meniscus, for example. We put them out, and then we see 5 years later that the joint is deteriorated. And we see ligaments which are ruptured, and we don't restore it. We see 5 or 10 years later that the joint is completely deteriorated and given osteoarthritic. So the idea for regenerative medicine is to see and identify the early stage of damages and causes, to cut them out and to cure them, to prevent the osteoarthritic deviation. That's the idea.
So you talked about the past. So how did the treatments for arthritis specifically change in the last 20, 50, 100 years?
Yeah, it has been changed, definitely. We learn since 15 years, 20 years, more and more about the molecular structure of the tissue itself. We see what is the role of hyaluronic acid, for example. This is a molecule which mostly will be synthesized by the body itself to cover the surface of the cartilage with a softy, low rigid material. And we see that the osteoarthritic knees, they lose the capacity for self-production of that molecule, for example. We can inject that. Now we have a treatment for early stage of osteoarthritic to inject the hyaluronic acid. It helps to reduce the friction and less inflammation. For example, we have PRP, platelet-rich plasma. It's a very new molecule what we use. It was synthesized by the platelets. We release that from the platelets and inject it in the knee. Normally, these molecules are not in the joint because the joint is covered from the rest system. Means if you could inject that, then you pushed 40 biomolecules for regenerative medicine in the joint. So it's a very new approach, and it's very successful and very low risk factors. In this molecule, everything what the body needs for regeneration, it's in. There are molecules which stimulated the ingrowth of vessels, which is for the nutrition important. They stimulated the differentiation from stem cells, which is important. So many factors stimulated the whole world of regenerative medicine based on the PRP.
But what did happen to the patients 100 years ago? Were there even any treatments for?
No, definitely not. There's no injection, there's no arthroscopic operation, there's no artificial joint. They have to go. And we learned that the stadium of osteoarthritic is curved, goes down, and in the final stadium where the cartilage is completely loosed, there the patient comes back to a low level of inflammation. So in the end of that course of osteoarthritic, there come up a phase which is less symptomatic. So they have to go further, and in the end, it was stiff knee.
But they can function properly, I think, if you have arthritis in the hands That's
a problem. You see on the end that the function is lost. So the range of motion is limited. The capacity for load is deficit, and the ligaments which normally control the movements are also damaged. So osteoarthritis means is a disease which affected the bone, the cartilage, the synovial tissue, the capsule, the ligaments, and the muscles. So everything is affected by that. And you see in the final stadium how it was damaged in all these tissues. So the idea is try it in an early stage to prevent the whole story in the end, because you cannot restore everything. This is not possible. You can only prevent by treatment in the early stage.
So would you maybe say that we have also today a problem, so that in the prevention of the arthritis, because I see a lot of old people that have really problem, to grab a cup, or my grandmother or my grandfather. Would you say we have a problem with the prevention?
Yeah. It is a question of detection and to create also patient sensitive for detection. To say not take a painkiller and wait, because wait and see is not a strategy to prevent the final stadium. It goes further. So the idea is to get sensitive, to say, oh, there's something wrong. Take a diagnostic and look if you can stop that process in a regenerative way. And don't wait for financing, because in the end it is damaged.
Does it play a role if you are female or male in arthritis?
Yeah, female have it's more age related over the postmenopause. So after 50 years old, the ladies increase in the incidence of osteoarthritis. It's mostly related to the hormones. So the female hormones are related to the metabolics of the bone that we know, but also related to the metabolic of the cartilage. So it disturbs that, and this is why we see a lift off of incidence in older female related to men.
Yeah, so there's a correlation between osteoarthritis and osteoporosis, I guess.
There's a relationship, but not a strong correlation.
No strong correlation.
Because it is very new knowledge about that. They work on that to analyze the circumscripting factors. But at that moment, there's not a clear relationship, because osteoarthritic, not all the ladies get osteoarthritic, which has osteoporosis.
Yeah.
It's not the same.
Just quick for our audience, osteoporosis is a disease, a disorder.
Bone on the bone, so it's atrophy of the bone density, which is related to the hormone regulation, and the cartilage metabolism is related to many other factors. But we see by the increase of incidence that there is a hormonal factors which define that.
Yes. We talked about the risk factors, and you told us that one of the main things beside the genetics is the overuse in sports, and especially David is really active. He plays volleyball, and he has sometimes some problems with his knee, and the problem is also known as the runner's knee. Would you maybe give our viewers some context about what a runner's knee is?
So in general, the overuse means that there is a lot of, I would say, G forces which addressed on the deformation of the cartilage. So if you jumped, you get a 3 or 3/4 higher energy application on the cartilage related to normal walk. So there's a huge difference related to jumping or something else. So we see, for example, sport activity which long runners, marathons, they have a rare incidence of osteoarthritis changes. And you have, for example, football player which have a 3.5 higher incidence to get an osteoarthritic knee after their career. So mostly the career is finished after 35 years, because mostly they have a damage in the joint. This is a normal way. Skier is also a high energy sport, that's for sure. And you see also they have ligament ruptures, they have meniscus tears, and they have loss of cartilage. The career is mostly out of that factors. for that reason, overuse is an important factor. And if you can select it, your sport, then you can prevent it a little bit to select a sport which is more accurate.
Don't go play football.
No. Sport with, football is very fine. You see sometimes football players which have a very rare damage on their knee because they are elegant and they walk fitly, they have muscles a lot. So you need a very high fitness grading for a sport like this one to prevent damage on your joint.
So once you have the runner's knee or jumper's knee or how as it is called, what are the treatment options?
So runners' knees for our jumpers' knees, they are typical overuse, but overuse which is addressed on ligament. So the anterior part of the knee are based on the ligaments on the patella and on the quadriceps tendon. So runner knees are located in the patella tendon. The patella tendon is address the forces of jumps or running, and they get an inflammation, a tendinitis of the tendon, and that hurts. That makes pain. So the therapy is reduce the overuse, indeed, that for sure, and reduce the tension of the muscle because the permanently power of the muscle pull on the tendon, and the tendon will have not a chance to regenerate itself. That's for sure. So you work with an anti-inflammatory, with changes in the activity and relaxation of the muscular tendon. This is typical treatment for that.
Yeah, I think it's really hard to stop what you are doing. I mean, I know I'm doing too much training, but it's very hard not to train because the overuse comes from something. Overuse means you constantly go to training and then not doing it is like...
Yeah, that is.
Yeah.
But in the end, what is the body doing during this disease? So normally you see that the tendon is inflamed, so you get an inflamed reaction. And then the body try to restore the cables like in the ligament. He build it up. But this cable production is very rare, means the restoration capacity of the cells is low. If you go out of the training, you see initially pain decrease initially. Then you are not ready for the constructive part. The constructive part is still working longer, up to 3 months.
3 months?
Yeah. It needs a lot of time that the structure can be restored itself. Means that people mostly go back to sport if the pain is decreasing. And if the pain is decreased, but the restoring is not perfect, they come back to a next inflammation, and they go back to the doctor, say, wow, it's hurting again. And it needs a long time to reduce that.
But if you have someone, for example, a football player or a basketball player that plays all the time, in which way they could prevent a runner's knee?
We work with the FIFA together. We have a 11 plus warming up technique. You can see that in the internet under the name 11 plus. This is transported to the whole of football clubs and other sports. It's a special warm-up training to give the best condition before you go active in the sport. So all the football clubs start with the 11 plus program to prevent injuries and to prevent overuse. So it's like a warming up system. And this is better. You start with a warming up, you give the tissue a little bit stimulating that they orientated the maximum for regenerative, and then you go in.
And also if the muscle is, also in my mind, if the muscle is very, very strong and can handle those forces, you're less likely to develop a runner's knee, right?
Yeah, the key point is not the muscle volume itself. So it's more the sensorimotorical capacity of the muscles. So they will control by nerves, and for everything what you do in a twisting or in a turning situation, this will be very calm, controlled by the stimulating of the muscles. So sensorimotorical capacity is quite more important as the muscle volume itself. So if you have a non-accurate working muscles, then the function of the joint is deteriorating. For that reason, the first step is to reduce the activity, to control the sensomotorical function, and then you go back to sport. So it's mostly the sensomotorical function which decrease initially. And this is one of the reasons what you have to control and to correct. Otherwise, you come back with the same pattern. You have like a motorical pattern in your brain. If you run, how you have to control the muscles under this condition. And if there's something wrong, you come up in an overuse for some part of the muscles. And then it's hurting. So you have to go back and analyze what is wrong. And then you have to control that, train it in an accurate way, and go back to normal sport.
And if someone suffers under a runner's knee, how does a training session of this person could look like?
To reduce the running knees?
Yes.
So mostly they come firstly out of the activity. It's a local anti-inflammatory therapy, which is based on manual therapy to stimulate the metabolic activity and the healing process in the joint, in the ligament. The second part is that you stretch the more tension. In the case that you have pain, then the muscle tension is much more higher, and this disturbs the nutrition of the tendon. Means you have to relax the muscles. That's important. Otherwise, it cannot come. And under this condition, you start with low-level activity, like with ergometer training or something else to warm up the tissue again, but under the highest level. And that you have to wait that the reaction is low, and you increase stepwise the activity under the level of pain.
Yeah, there's some kind of load management.
Yeah,
you could
that's
say.
a load management, but symptomatic related. So you have to look how it looks, give it pain, and then you go forward. There are some injections too, for example. You can PRP inject it under ligaments, which helps. We avoid corticosteroid injection on ligaments because that deteriorated the metabolism of the tissue. And they create also tendon ruptures. So for that, you have to avoid, whenever it's possible, the corticosteroid. For supplying the regenerative way, the PRP would be now in sport relation therapies the best one.
What would happen if you train through a runner's knee? If you don't feel pain at all and you just go train, but you actually have a runner's knee, what would happen?
No. So you have the physiological adaptation. So for a long run, for example, you repeat all the time the same distance, 1 kilometer per day, 2 kilometers, so increase stepwise. And this is in a training concept where the tissue can be adapted to the higher load over the time. So this is the good training. The bad training is you go in a muscle machine and increase the load maximum in big steps. Then you come on a point where you overload it, and then you have a tendinitis. If the tendinitis is initiated, then it needs a long time to come back. So the prevention in the way how you act your tissue, it's the most relevant point. Like 11 plus, like warming up, like training, like this one.
So I have a last question to the runner's knee. I mean, there are for sure some patients who just don't listen, right? So what will they get if they just really don't listen to their doctor? They go train hard, intense over a month, even if they have a runner's knee. What will happen to their joints, ligaments?
So if you have a high mechanical load on a structure which is permanently inflamed, then the structure loses on their own capacity. Means you lose collagen cables, and in the end, partially you see necrotic area in the tendon.
So it dies.
Yeah, it's deteriorated again. The mechanical resistance comes lower, and we see some situation that it ruptured. We see that on the Achilles tendon. We see that on the patella tendon. So we see it in different tendons. It's the same situation. Tennis elbow. So many overloaded on the tendon if it comes chronically, the structure will lose, and in the end, there is a higher risk for rupture of the tendon.
And how long would it take to regenerate a ruptured tendon?
The ruptured tendon has to be supported by suturing of a surgery.
Yeah.
That's for sure. And it needs approximately 3 months to a half year if it's stable enough to go back to sport. Minimum. So mostly, if, for example, the Achilles tendon is ruptured, you are out of sport. Minimum half year to 7.5 months. Because the body cannot build it up faster. There is nothing on our side where we can speed it up. Mostly if you have athletes which work for that, they have everyday physiotherapy, they have everyday trainings, they take a lot of pills and support it and nutritions. But in the end, the speed for regeneration, it's limited by the capacity of the tissue. You cannot speed it up. Means out of sport is a consequence of the low speed of regeneration. That's a caution.
So
I
listen,
always have the question that, can we go back in 3 months? Can the football player come back in the field after 3 months? Something, because the clubs want to see that clear, but it's not possible.
So listen to your doctors. Take time off sometimes. Yeah.
Yes. So our conversation is slowly coming to an end, Mr. Steinwachs. Unfortunately, yes. But I would like to know at least if you had the power to change something about the health industry. Is there something that you would change like this?
Yeah, of course. In general, I built up a lot of regenerative surgical techniques in my life, and I use biomaterials and molecules together. And mostly the companies or the med tech give me a material and say, look what you can do with that. So it is not focused on that what I need. For example, if I want to rebuild a tendon, I need another supporting structure for the rebuilding of the tissue as I fix the bone. Okay? I would say the main factor is that the medtech has to be work under the superiority of the surgeon. The surgeon say, I need a material which has this characteristic, and build it up. And then you give it. And not in the way, we have something, take it. And we see after 2 years that it is a worse material and it has to be dropped out. That is the reality what we have. So everything what we have in the innovation medtech is mostly more addressed of economical or production processes as addressed to the patient. For that reason, I would like to change that we say what we need and the companies produce that. That's the way.
But why don't they? What is the
It's
reason?
completely independent business, because our business is based on the insurance and their business is on the big market, whatever. And they look for their own
benefit.
Owners, not for the patient and not for the doctors.
Yeah, so it's in the end also kind of a money game, I guess. Yeah.
Absolutely, it's a big money game. And if you see that doctors and hospitals are under high pressure of economical situation, on the other hand, we have medtech or pharmacy, which are mostly independent on that, and they do their own work, but they are not realized that they create a lot of higher economical costs with their business. But it is not completely integrated. Nobody play or discuss that with them.
So as a last question to finish this podcast off, what is your end goal in your career?
I think I have my end goal in my career, because everything what I dream. So for me, it was how I can integrate new regenerative medicine in my daily work in the orthopedic or musculoskeletal field. And I could do a lot of research based on universities and also ETH. This is a great opportunity that I could realize a lot of my knowledge based on the research. It's absolutely elemental to have this information if you create a new treatment, because you need to know what the cells do, what the biomaterial do, what the nutrition is, what the mechanical factor is, blah, blah, blah. This whole knowledge you need in one person. I'm so lucky that I could collected all this information in my mind to create sufficient new therapies. And this is was my big goal, and I reached that. I'm, from my point, completely happy with my situation.
That's very, very cool if you can say that about yourself. Yeah.
That's really nice to hear that. And with those final words, our today's episode comes to an end. Mr. Steinwachs, we really enjoyed the time with you. We hope so have you. And yes, thanks for your time.
And I thank you for these interesting interviews and questions. I enjoyed them.
You're welcome.
Thank you.
Thanks for watching, guys. We really hope that you've learned something new today. And if you like what we do and are interested in medical contact, so please leave a like, subscribe and activate the bell so that you don't miss anything new.